So good afternoon. My name is Luisa Borrell. I'm the chair of the Department of Epidemiology and Biostatistics, and it's more than a pleasure to introduce Nancy Krieger. Nancy Krieger is a professor of social epidemiology and American Cancer Society, clinical research professor at the Harvard T.H. Chan School of Public Health, where she directs the interdisciplinary concentration on women, gender, and health. She's a renowned and internationally recognized social epidemiology with a background in biochemistry, philosophy of science, and history of public health. In addition to that, she has over 30 years of activism involving social justice, science, and public health. She has over 250 publications, 4 books, and over 700 non-peer-reviewed publications. That has earned her to be among a selected group of scientists. Since 2004, she has been one of the ISI highly cited scientists, where only less than one half or 1% of scientists that publish is in that group. Her work can be seen as 3 different prongs: conceptual framework, in which she aimed from the get-go to understand, analyze, and improve the health of population. And we all know the ecosocial theory of disease distribution proposed by her in 1994. We have all seen the spider by now. Second, she has focused on etiologic research on societal determinants of population health and health inequity. And finally, her methodological contribution to the field of public health are enormous. So without any delay, it is my pleasure on behalf of the Department of Epidemiology and Biostatistics to introduce you to Professor Nancy Krieger.
So good afternoon. I'm delighted to speak at your grand rounds, and I thank Professor Luisa Borrell and also Dean Ayman Al-Mohandes, who I understand is ill and can't be with us today, but I really appreciate the invitation. I look forward very much to the Q&A after I give my 40-minute talk, and as you can see, the talk is titled Inheritance and Health, What Really Matters for Health Equity, Considering History, Jim Crow, and Racialized Economic Segregation. Please note that I've prepared a handout with relevant references. So you should have access to that, and I'm not sure how you get that, but you should have access to that when it gives all the references that you will get in the talk, so you don't have to worry about catching them. But the slides are not for distribution. And so I invite you to sit back and take in a lecture that is historical and conceptual and empirical. So the focus is on the relevance of inheritance to population health and health equity. And I'll start by asking you 3 questions. When I say inheritance matters, how many of you think I mean biological inheritance, that is heredity? There's a few brave people that raise your hands. How many of you think that I mean societal inheritance pertaining to private and social wealth and resources passed from one generation to the next? Good, a lot more of you raise your hand. How many of you have ever wondered about the implications of the dual meanings of the word inheritance for our work in public health? Very few. That's typically the case. But keep these questions in mind as I present my talk, where I'll first offer some critical thoughts on inheritance and health and focus on my 2 empirical examples regarding the health impacts of first, spatial social polarization on health, as quantified using the index of concentration at the extremes, including for racialized economic segregation, and secondly, Jim Crow and its contemporary health inequities. Guiding my critique is the ecosocial theory of disease distribution, which, as Luisa mentioned, I first proposed in 1994 and have been elaborating since. In brief, ecosocial theory is centrally concerned conceptually with who and what drives current and changing patterns of social inequalities in health. Viewing population health and health inequities as embodied history, ecosocial theory accordingly pays heed to societal and ecological context, to I was told the slides do that. That's interesting. To life course and historical generation, to levels of analysis, and to interrelationships between diverse forms of social inequality, including but not limited to racism, class, gender, and sexuality. A key focus is on embodiment, referring to how we literally embody biologically our societal and ecological contexts across levels and generations, thereby creating population patterns of health, disease, and well-being. Also, another concern is on accountability and agency, both for social inequities in health and for the ways they are or are not monitored, analyzed, and addressed. First, however, we need to ground ourselves in the current realities of global and U.S. wealth and income inequities. The map in the upper middle, whose origins lie in the World Mapper project that my colleague Danny Dorling and others launched back in 2005, shows countries scaled to size in relation to the metric displayed. The top row shows the distribution of the world's population in 2015, and the bottom shows the distribution of countries' gross domestic product. As you can readily see, most of the world's population obviously lives in India, China, and the many countries in the African continent. But countries' GDP, as you also well know, is a starkly different distribution, with the high end dominated by the US, Europe, and Japan. Moreover, these economic inequities have been growing. In its 2018 report, Reward Work, Not Wealth, Oxfam pointedly observed last year's increase in the number of billionaires is the highest ever. In 12 months, they made enough money to end world poverty 7 times over, with 82% of all new wealth created in this period going to the top 1%, while zero has gone to the world's poorest 50%. As Piketty has documented, without active government regulation, the wealthy expand their wealth way faster than wage earners can increase their income. But of course, on average data for countries is merely that, on average, and tells you nothing about within countries inequities. The graphic on the top left from the Gapminder, on top right from the Gapminder project, usefully depicts skewed income distributions within countries, with global regions sorted by color. The U.S. is the green region and, like many others, has a long tail towards lower income. And within the U.S., current concentrations of wealth and mounting income inequality now rival their 20th century high reached in 1929, right before the stock market crash and the Great Depression. The ratio of the incomes of the top 0.1% of the U.S. households with the average household in the bottom 90% grew from 47 to 1 in 1980 to an astounding 206 to 1 in 2011. The U.S. black-white wealth gap, which began shrinking in the late 1980s, started growing again in 2004, with the ratio of white to black median household income growing from 8 in 1983 to 13 in 2013. The U.S. ranks high in the top 1% shares of the national wealth, far higher than other wealthy countries, and likewise has lower intergenerational mobility and higher economic inequality. Reflective of the U.S. origins as a colonial settler nation and a slave republic, among U.S. racial ethnic groups for whom the U.S. Census provides data on net worth, Black Americans fare worse, and no data are provided whatsoever for American Indians. So with this context in mind, consider the word inheritance. As my initial 3 questions suggested, on its own, this term conjures up 2 primary meanings. One is biological, the other is social, and both are deeply entangled at cross purposes in current understandings of who and what matters for improving population health and advancing health equity. In the U.S., a deeply polarized Congress is happy to support research on gene editing to cure diseases, while simultaneously brawling over funding the Children's Health Insurance Program and slashing taxes for corporations and the wealthy. These stark juxtapositions make it critical to ask what type of inheritance truly matters for the people's health. Surprising guidance may be found in the work of the Danish pharmacologist and plant physiologist Wilhelm Johannsen, who in 1909 coined the terms gene, genotype, and phenotype. When he introduced these words to the English-speaking scientific world in 1911, Johannsen worried, rightly so, that uncritical use of the term inheritance in the field of genetics would muddy the waters and confuse scientific understanding. The opening paragraphs of his profoundly influential paper could not have been clearer. Quote, "Biology has evidently borrowed the terms heredity and inheritance from everyday language, in which the meaning of these words is the transmission of money or things, rights or duties, or even ideas and knowledge from one person to another or some others, the heirs or inheritors. The transmission of properties, these may be things owned or peculiar qualities from parents to their children, or from more or less remote ancestors to their descendants, has been regarded as the essential point in the discussion of heredity in biology, as in jurisprudence. Here we have nothing to do with the latter. As to biology, the students of this science have again and again tried to conceive or quote-unquote explain the presumed transmission of general or peculiar characteristics and qualities quote-unquote inherited from parents or more remote ancestors. The view of natural inheritance as realized by an act of transmission vis-a-vis the transmission of parents or ancestors' personal qualities to the progeny is the most naive and oldest conception of heredity, end quote. Johannsen spent the rest of his essay debunking this false notion of biological transmission of traits. To do so, he introduced the profound conceptual distinction between genotype and phenotype. He also refuted the seductive but false notions of quote-unquote blending of parental traits and offspring, a fallacious view underlying the eugenic statistics of Sir Francis Galton and Carl Pearson's highly influential biometrics. To Johannsen, the genotype could never simply be a catalog of discrete genes. Instead, it was a dynamic system created by their complex interactions. Nor could an organism's equally dynamic phenotype be simply read off or reduced to its genotype. Rather, the key questions identified by Johannsen was that of understanding what he called reaction norms, that is, how pure-line organisms, that is, self-fertilized bean plants that were inbred for several generations, could, under different environmental conditions, yield both organisms with different individual phenotypes and also populations with different patterns of variability in these phenotypes. Johannsen's crucial insights have been resoundingly supported by a subsequent century of research. New knowledge about the epigenetic regulation of genes, biological development, and speciation have clarified that all of these phenomena causally depend on living organisms' two-way engagement with the ecosystems and the local environs that they, including us humans, necessarily inhabit and shape, in concert with a rich mix of other members of the same and other species. A corollary is that well-being, distress, and disease, whether physical, mental, or both, are embodied expressions of the dynamic, flexible, and emergent phenotypes of organisms across their life courses. Nevertheless, dominant scientific medical institutions in both the U.S. and the worldwide primarily devote their attention and resources to genotypes, not phenotypes or the environs that shape them. Precision medicine is promoted for the cure of humanity's ills, whereby knowledge of genomics can be used to fine-tune the prescription and design of medications, and that, of course, is extremely important. And it is also claimed aid prevention via personally guiding people to modify their health habits, which is much more dubious. All the more reason, then, for public health professionals and advocates to clarify to politicians, policymakers, clinicians, and other scientists, as well as the broader public, that effective strategies for reducing the incidence of leading types of disease and injuries within and across countries, as well as reducing inequities in their rates, will not be achieved by a narrow focus on genomes and biological inheritance. Rather, it is the decidedly non-biological, acquisitive inheritance to which attention must be turned. Societal policies and economies promoting social, economic, and environmental equity have long been fundamental to promoting both population health and health equity, and can do this at a scale that way dwarfs the reach of biomedicine. This is why public health exists. It is accordingly worth heeding another key insight in Johannsen's essay. Quote, "It is a well-established fact that language is not only our servant when we wish to express or even conceal our thoughts, but that it may also be our master, overpowering us by means of the notions attached to current words. This fact is the reason why it is desirable to create a new terminology in all cases where new or revised conceptions are being developed. Old terms are mostly compromised by their applications in antiquated or erroneous theories and systems from which they carry splinters of inadequate ideas, not always harmless to developing insight. Therefore, I have proposed the terms gene and genotype, and some further terms as phenotype and biotype to be used in the science of genetics," end quote. Imagine, then, a world in which inheritance receives its due as a key determinant of population health, but with its meaning restricted solely to the societal forms of intergenerational transfers of wealth, resources, knowledge, and traditions, which Johannsen both recognized and carefully distinguished from the hereditary transfer of genes from ancestors to descendants via gametes. After all, As history has shown, it has been again the societal regulation and restriction of massive concentrations of private inheritance, along with promotion of public inheritance and support for shared and inclusive knowledge, that has best enabled societies to improve population health and promote health equity. Imagine if proposals and analysis of policies, regulations, and budget appropriations roundly took on inheritance, framed not in genetic terms, but in terms of the biological toll within and across generations of soaring private accumulations of inheritable wealth extracted inequitably from people, other species, land, water, and the shared planet on which we all must live. Imagine the productive debates that would ensue about the relevance of which kinds of inheritance, social versus germline, matter for health and health equity. The key point is that the public health argument must be amplified. The type of inheritance that matters most for understanding and changing rates of disease and magnitude of health inequities is societal, not biological. Contextualized phenotypes, not decontextualized genomes, must be the focus for research and interventions to alter population disease profiles and promote health equity. Without such a shift, future generations will have a grossly reduced likelihood of inheriting a world in which all can live healthy lives, which requires sustainable and equitable economies that enable ecosystems and their myriad species, including us humans, to thrive. So I'll shift now to two sets of empirical examples, both of which are intimately bound up with long-standing controversies over which sorts of inheritance matter for health and health equity, genetic versus societal, especially in relation to racial ethnic health inequities. Before I present the examples regarding health in relation to first Jim Crow and second racialized economic segregation, a bit more context is key. So first, a few brief visual reminders. To the right are images from last August, hateful, hate-filled, and murderous alt-right white supremacist neo-Nazi conclave in Charlottesville, Virginia, which led to the death of Heirs and injury of 34 others. To the left, images from Boston's counter-protest a few days later, whose 40,000 plus participants, including yours truly, eclipsed the puny alt-right rally, which included, fortunately, fewer than 50 extremists. I could add much else, including the rescinding of DACA on September 5th, attacks on voting rights on account of non-existent voter fraud, as opposed to investigating voter roll hacking, not to mention extreme partisan gerrymandering, and both crude and sophisticated U.S. and foreign manipulation of social media, lies, propaganda via the internet. I could mention militarized policing, racialized police brutality, and the militarized response to the profound struggle at Standing Rock against the Dakota Access Pipeline and more, but these images do set the stage. Second, it is essential to emphasize that the white supremacist and neo-Nazi belief in innate racial difference and racial superiority and inferiority obviously are not new. Rather, they draw from a long legacy of scientific racism, a doctrine generated by the thinking and work of highly educated people. These racist views cannot be dismissed as simply a product of ignorance or scientific illiteracy. Instead, the supposition that humans are divided into biologically distinct races, with some superior and others inferior, has blighted modern scientific thought since at least the 1500s. Its origins and sustenance can be traced to systems of slavery and colonialism, whereby scientific racism provided a justifying ideology for the conquerors about their subjugation of those whom they militarily defeated and enslaved. On this slide, I show a few key images. Shown seated in a photo taken in 1872 is Harvard's illustrious professor Louis Agassiz, a celebrated intellectual. Agassiz, who had immigrated to the U.S. from Europe, candidly wrote about how he felt revulsion when he first saw a black person in the U.S. In the mid-1800s, he contributed a key opening essay to the notorious racist 800-page tome compiled by Josiah Nott and George Glidden, two U.S. white men, one a physician, the other an amateur Egyptologist. This book promulgated the doctrine of quote-unquote polygenesis, which held that different types of humans constituted different species, as different species of animals, per the illustration Nott and Glidden made, shown here for Agassiz's essay. Nott and Glidden also produced the image shown here that vividly depicts Africans as an intermediate species located somewhere between the allegedly noble Greeks and the lowly chimpanzee. By the early 20th century, scientific racism was embedded in the scientific mainstream via the dogma of eugenics, a doctrine promulgated by highly educated scientists and physicians. As a term, eugenics was coined in 1889 by Sir Francis Galton, a cousin of Darwin, and an eminent British scientist and mathematician. Eugenics held that people's inborn, inherited biological constitution was the key determinant of success for both individuals and the biological races to which they belonged. Although Galton recognized that there was variation within types and readily conceded that, say, there could be an African whose intellect surpassed that of most white persons, nevertheless, Galton held it to be a basic biological fact that Africans on average were innately inferior to Anglo-Saxons. During the early 20th century, U.S. eugenicists were ardent educators and created traveling exhibits to teach people across the U.S. about their views of genetics and human breeding, and as shown here, illustrated issues of color inheritance via provocative and simplistic displays of black versus white rats. Eugenicists left a notable stamp on U.S. laws and policies. Strong supporters of Anglo-Saxon and Aryan supremacy, they were critical to the development and passage of the 1924 and 1927 U.S. Immigration Restriction Acts, which favored immigrants from Northern Europe and opposed drastic cuts and permitted quotas from anywhere else, and not changed until the 1965 alteration of U.S. immigration policy. They were also key to enacting sterilization laws in 33 U.S. states. Indeed, as Leonard documents in his new book, Illiberal Reformers, in the early 20th century, those who, quote, advocated exclusion of hereditary inferiors read like a who's who of American economic reform. They were joined by the founders of American sociology, pioneering social work professionals, leading Protestant social gospelers, university presidents, political jurists, U.S. presidents, among others, end quote. One such president was President Theodore Roosevelt, as illustrated by this iconic statue, which I'm sure many of you have seen, which sits outside the New York City Museum of Natural History, and which shows him, the triumphant white man, with the American Indian and African in tow. The president of the Museum of Natural History, Henry Fairfield Osborn, was likewise an ardent eugenicist, as was the longest-serving president of Harvard University, Charles William Eliot, who served in this role from 1869 to 1909. And as Leonard further notes, in the early 1900s, quote, eugenics was a staple of the biology curriculum at all levels, end quote. Moreover, as I was shocked to learn as a sophomore in college from Alan Chase's 1977 book on the legacy of Malthus, The Social Costs of the New Scientific Racism, the Nazis borrowed extensively from U.S. racist eugenic sterilization laws, and their policies of racial hygiene were explicitly modeled after U.S. Jim Crow laws, as well as the 1924 and 1927 U.S. Immigration Restriction Act. Yet, as per the alt-right demonstrations and the progressive counter-protests this past summer, my second key point is that just as scientific racism has a long legacy, so too does the history of challenging it. This slide just shows a few key illustrious 19th century physicians who intellectually tore apart the shoddy airset science of scientific racism. Dr. James McCune Smith in the early 1800s became the first African American to receive an MD, a credentialed MD, and who, in addition to providing care to the black and indigenous population of the city, New York City, was an abolitionist and wrote a devastating critique of Thomas Jefferson's beliefs in innate biological inequality. In the mid-1800s, Dr. John S. Rock, a physician, abolitionist, and lawyer, likewise wrote trenchant critiques of scientific racism and was the first African-American to be admitted to practice before the U.S. Supreme Court. Dr. Suzanne Laflèche-Picotte in the late 1800s became the first American Indian to receive an MD in this country, and having witnessed a sick American Indian woman die because a white physician refused to give her care, throughout her career she played a critical role in challenging racist medical practices. These three are among a very long line of courageous critical thinkers and practitioners. To raise awareness about such contributions, last spring, as part of my school's event on public health and slavery, past, present, and future, we invited a local artist, Lisa Rakowski, to transform our school's key entryway, whose paintings at that point featured prior deans and who, not surprisingly, were virtually all white men. Her ghost portraits added to the wall silvery images of key late 19th and early 20th century African American and American Indian public leaders, who at the time would never have been included in the Harvard faculty. The space now asks us to see the loss and make the invisible visible. Also this past year, we've come to live in a time in which so-called alternative facts have a political valence that is used to trump, pun intended, bona fide scientific evidence, especially about climate change. During this past year, U.S. scientists have led unprecedented public demonstrations to quote-unquote stand up for science, including one that was in Boston in February 2017, which packed Copley Square. The National March for Science in Washington, D.C. last April had 600-plus satellite marches worldwide. But is it enough simply to stand up for science, given the history that I have recounted? No. We must also ask, who's science? Eugenics, after all, claims to be a science, and scientists likewise have been deeply involved in the science of fossil fuel extraction and use, weapons, and most recently, big data science to advance conservative political agendas, as I'm sure many of you are aware through following what's going on right now with Facebook and Cambridge Analytica. So with this history and these questions in mind, consider first the health impact of Jim Crow and its abolition in the mid-1960s. As many of you know, starting in the 1880s and 1890s, as backlash to the Reconstruction after the Civil War, the system of Jim Crow was created and became the law of the land in 21 U.S. states plus the District of Columbia, with de facto discrimination operative in the remaining 29 states. In essence, it was a form of structural, legal, racial discrimination backed by the state and upheld by violence and terror. Directed chiefly against Black Americans, but also encompassing other racial ethnic groups legally defined as quote-unquote not white, for example, American Indians and Asian Americans, Jim Crow laws imposed legal restrictions for Black and other quote-unquote non-white persons, and created legal privileges for white persons in such domains as education, transportation, hospital and penal institutions, welfare institutions, employment, marriage, public accommodations, other public venues, and voting, all of which are major determinants of population health and health inequities. These laws were so numerous that they filled 524 pages in small font. In the path-breaking text, States Laws on Races and Color, the first comprehensive compilation of state and local ordinances published in 1950 by Pauli Murray. This slide offers a few examples with the photos showing Jim Crow in action in relation to public accommodations, public transportation, and water fountains. And Jim Crow's abolition was only 53 years ago, a mere instant when considered in relation to historical generations. Any U.S.-born person at age 53 and older, which includes me, by the way, was born when Jim Crow was the law of the land, combined with de facto discrimination in the non-Jim Crow states. Anyone in their age 70s and older, the age group in which the bulk of U.S. mortality now occurs, was at least 20 and perhaps had their first child when Jim Crow was legal. Think life course. We are reckoning with embodied history within and across generations. This background makes it all the more shocking that when I first started exploring work on contemporary health effects of Jim Crow a few years ago, I learned that the number of such studies literally could be counted on one hand, 5. This surprised me for 2 reasons. First, Jim Crow can plausibly be hypothesized to be a major social determinant of health, given how its legally codified system of white supremacy, bolstered by extrajudicial terror, structured exposure of Black Americans to horrifically noxious conditions. And secondly, its abolition was not that long ago, that is, in living memory. And again, for any of you who think that Jim Crow is ancient history, do the math. Look at this table, which considers 7 different birth cohorts and asks how old their members were in 1965, how old they are now, and whether their parents were likely to be born before 1965, or whether they themselves became a parent before 1965. Ask yourself, how old were you in 1965, or your parents, or your grandparents? On that note, here is the visual description of the results of our first study, which looked at infant death rates, and our findings make even more shocking the lack of research on this topic, given that the number of persons affected is large. Specifically, as shown on this slide, nearly 2/3 of all Black infants born in 1960 to 64 were born in those 21 Jim Crow states plus D.C., and they are now in their 50s. Again, this is living history, alive within us. It's not the ancient past. These slides show the descriptive results for infant death rates for the U.S. Black and white populations in the Jim Crow and non-Jim Crow states. Our graph includes data for not only the computerized U.S. mortality records commencing in 1959, which are the black lines, but also U.S. state-level vital statistics data we hand-tabulated for 1940, 50, and 60, which are the gray lines. What appears is a singular convergence in the U.S. Black infant death rates for the Jim Crow versus non-Jim Crow polities that occurred between 65 and early 70s, a finding corroborated by the results of our much more sophisticated statistical analyses. Our analysis of premature mortality, that is death before age 65, reveals similar trends, a marked effect for African Americans, not for white Americans. In other work, we've newly shown in the first ever studies to look at Jim Crow and cancer that among contemporary U.S. women diagnosed with breast cancer, most of whom are in their 60s or older, that Jim Crow birthplace is associated among U.S. black women with breast cancer lethality by increasing the risk of being diagnosed with a tumor that is estrogen receptor positive, that is, a type of tumor that is unresponsive to pharmacologic treatments that improve survival for patients with estrogen receptor positive tumors. Where does inheritance fit in this story? Well, what motivated our research are both, first, the persistent unresolved questions about social versus genetic causes of the U.S. black versus white excess of ER-negative tumors, especially at younger ages. And second, empirical evidence on the historical contingency of the population distribution of and also social inequities in breast cancer ER status. Thus, despite enormous heterogeneity in breast cancer ER status in and across diverse African nations, as has just been shown by a recent first ever meta-analysis, mainstream U.S. research astonishingly refers to quote-unquote African breast cancer and focuses on genetic causes of black versus white disparities in ER-negative tumors, even as there are, of course, a handful of researchers who do call attention to the likely social drivers that are potentially malleable of these disparities. Suggestively, the U.S. black versus white ER-negative excess risk rose in the 1990s, but then this risk fell following the 2002 publication of the Women's Health Initiative results, which showed that hormone therapy increased risk of breast cancer, and especially ER-positive breast cancer, without conferring protection for cardiovascular disease, and that led to its declining use among women who had access to this medication, who were predominantly white and affluent, and as their rates of using hormone replacement therapy fell, so too did their likelihood of having ER-positive breast tumors, which brought them more on par with what had been the experience of the women who weren't using hormone therapy. For our first study, we used data from the U.S. Year 13 Registry Group and focused on all U.S.-born black and white women ages 25 to 84 diagnosis who were diagnosed with primary invasive breast cancer between 1992 and 2012. Our key finding was that risk of having an ER-negative tumor was greater among the U.S. black women born in a Jim Crow versus non-Jim Crow state, for those who were born before 1965, and no such Jim Crow effect was evident among the white women. In our second study, just published, we considered the problem from the standpoint of biological generations and asked what the pace of change was in the percentage of ER-positive cases diagnosed among this group of women using a measure from evolutionary biology, the Haldane, which measures the pace of change in phenotypic standard deviations per generation. I won't get into the Haldane here, but I'm happy to answer questions about it. On this slide, I show the trends for ER-positive tumors, where you're looking at the proportion of tumors that are ER-positive. Three findings stand out. First, the percent of ER-positive cases rose by birth cohort from women born 1915 to 1919 to those born up to 1975 to 79, only among the women who were diagnosed before age 55. So this is the age group which is often said to have a genetic component. Second, changes by biological generation were much greater for the black compared to white women, and among the black women were greatest for those born in the Jim Crow versus non-Jim Crow states. And third, the net impact was among women under age 55 to close the black-white gap in ER-positive tumors by half. Such rapid phenotypic change can plausibly only be driven by factors exogenous to populations' genomes, despite the emphasis of the literature on genetic contributions to black versus white risk of ER-negative tumors, especially at younger ages. By contrast, among women aged 55 and older at diagnosis, no trend was evident among the black women, whereas the white women exhibited a slight decline in percent ER-positive over time, which may again be tied to changes in use of hormone therapy. The larger implication is that Jim Crow not only casts a long shadow on current patterns of population health, but also that it is woefully inadequate and not at all scientifically rigorous to bring only the idea of biological inheritance to analysis of racial ethnic health inequities. What is required is a deep sense of the relevant histories of societal inheritance. Jim Crow remains in current patterns of local residential segregation, which in turn affect people's present-day health. It is important to remember that we don't live simply in unjust societies. We live in places. And no matter how much of our lives or livelihood may roam about in cyberspace or be engaged with non-geographically defined communities or interest groups of one form or another, issues of residence, economics, power, and health are tightly bound, as is the intergenerational inheritance of property and privilege or lack thereof. Consider, for example, recent research showing that current spatial patterns of racialized impoverishment in Jim Crow states are associated with earlier spatial distributions of enslavement and greater severity of Jim Crow regimes. Over the past few years, I found myself wondering if there was more that we in public health could do to discern the public health ramifications of growing extreme concentrations of income and wealth, to bring into view those who benefit from a status quo in which working families are below the poverty line while the proverbial middle is being hollowed out. At issue is residential economic segregation, which in the U.S. is heavily racialized. The value of using measures of segregation is because they capture and portray inequity as a social relationship, because segregation by definition involves two or more social groups. One cannot focus on, say, solely impoverished persons. Instead, in any such measure, affluent persons are part of the picture as well. However, upon delving more deeply into the public health and social science literature, I confronted two problems. First, work seemed to focus primarily on racial segregation, often controlling for socioeconomic position, or sometimes looked at economic segregation, often not taking into account race ethnicity. And the two phenomena were rarely studied together, in part technically because measures of these two types of segregation typically can't be put into the same model, given correlation. Second, I found that most studies measured segregation only at the city level or above, precisely because social polarization within cities means that most conventional measures can't be used for smaller areas. For example, the Gini index of income inequality is the same for a neighborhood in which everyone is impoverished or one in which everyone is affluent. And the same kind of problem affects the main measure used for racial segregation, the index of dissimilarity. Third, although I did find some newer measures of local segregation, all continued to cleave racial and economic segregation, and they also problematically and conceptualize and operationalize this kind of segregation as solely relative measures. So, rummaging around in the social science literature, I came across an intriguing measure developed in 2001 by Douglas Massey, one of the leading U.S. scholars on racial segregation. He termed his metric the index of concentration at the extremes, or ICE, and he designed it to be a measure of spatial social polarization, one that could be computed at multiple scales and levels of geography. Ranging from -1 to 1, and calculated by the provocative and deceptively simple formula shown on this slide, the ICE uniquely captures in a single metric the extent to which an area's population is or is not concentrated at one or the other end of a spectrum of privilege and deprivation. At issue, obviously, are various pathways involving the impact of the spatial polarization on local education, economies, environments, and ecologies, as well as spatial and economic access to health services. To date, the ICE has been used in a variety of social science studies, but in only a handful of public health investigations. In all of these studies, the ICE measures have pertained previously solely to socioeconomic inequality, with these measures consistently associated with diverse social and health outcomes, independent of individual or household level data. Our novel contribution has been to extend the use of the ICE to measure both racial segregation and also racialized economic segregation, and to do so in a multi-level framework. No such joint measures of racialized economic segregation have previously been used in the population health literature. So let me now share with you some results from several of my new projects here in New York City, in Boston, and in Massachusetts overall, to explore whether the ICE might have value as a metric for monitoring and analyzing health inequities. The objective is to bring back onto the map, literally and politically, the societal relationships that underlie the health inequities that we see and are trying to change. I'll start by showing these maps for our New York City project, which show the quintile distributions for census tracts of the 3 ICE measures we've computed and also the poverty level. The ICE for income sets as extremes the persons in the top versus bottom household income quintile. The ICE for race ethnicity related to racial privilege defines white non-Hispanic as the privileged category and black non-Hispanic as the group deprived of racial privilege. The ICE for income and race ethnicity is in turn set as the extremes of high-income white non-Hispanic persons versus low-income black non-Hispanic persons. The spatial patterning of the extreme concentrations of privilege and deprivation is stark and clearly shows a tale of two cities. Note, too, that the patterns are not identical for the ICE for income versus the one for race ethnicity, and neither of these ICE measures maps directly onto the poverty level. Something different is being shown. But of course, in the U.S., one cannot simply look at cities given the joint phenomena of suburbs, white flight, and the so-called bedroom communities for people who live near to, but not in cities in which they work, thus shrinking the city's tax base. Here you can see these social spatial patterns play out for the greater Boston area, especially with regard to the extreme concentration of white persons and high-income persons outside of Boston city's boundaries versus the extreme concentrations of black persons and low-income persons evident in Boston, which is the inset. This sort of map provides a big clue that, for example, racial, ethnic, or economic comparisons constrained solely to Boston will miss a large chunk of fellow residents of the state living in areas with far more resources. And it also makes one pause to think about the selection effects of which white persons do versus do not live in the city itself, and which populations of color live outside of the city bounds. And how about the connection to health? I'll first share with you results of a recent study conducted in collaboration with the New York City Department of Health and Mental Hygiene. And though this be but one city, it's worth recalling that your population size of just over 8 million means that you have a population that's larger than half the countries in the European Union. This slide shows results for premature mortality and diabetes mortality. And what you can see is that the greatest gap in risk, comparing people in the worst off to best off areas, was detected using the measure of racialized economic segregation as compared to the more conventionally used measures pertaining solely to racial segregation or income segregation or even just the U.S. poverty line. This next study, conducted within the greater Boston area, also suggests the ICE may be useful for analyses of air pollution. For this study, we geocoded the records of participants in two Boston-based studies that I had led. United for Health study, which was of working-class white, black, and Latino workers who were employed in diverse job settings, for example, light bulb manufacturing, school bus drivers, and grocery clerks. And then also the My Body, My Story study, which recruited a random sample of black and white, non-Hispanic adult members from 4 Boston community health centers. We linked these records to each individual's cumulative black carbon exposure at their residential address for the year prior to the date of their health interview, and we also linked their records to their census tract ICE measures. And with the models that controlled for relevant covariates, all 3 of the ICE measures were inversely associated with the exposure, that is, more privilege, less exposure. And the same could not be said for the participants' household income or for the individual level. What mattered was where they lived. We then extended these analyses to explore the association of the census tract ICE measures with hypertensive, as categorized based on data obtained through a physical exam. And here again, we found that the ICE measures, including an additional one that we computed for education, were in models controlling for relevant covariates inversely associated with risk of hypertension. Again, more privilege, lower risk. And once again, the same could not be said for household income and could barely be said for education. And again, the steepest gradient was observed for the ICE for racialized economic segregation. We then expanded our analyses to include the entire state of Massachusetts and focused on risk of fatal and non-fatal assaults for both total and firearm related for the time period 1995 to 2010. Our a priori hypotheses were that first, effect estimates would be greater for census tract compared to city-town ICE measures. And remember, our prior, so we couldn't compare how measures worked across cities. And second, the ICE measures would detect larger gradients in the index of dissimilarity for black versus white residential segregation and also the U.S. poverty level. So this slide shows the rate ratio estimates and their 95% confidence intervals for fatal assaults based on our multi-level analyses, which included random effects at the county and city-town levels plus adjusted for key covariates are for each of the bottom 4 quintiles compared to the best-off quintile. 3 patterns stand out. First, the steepest gradients were for the ICE for racialized economic segregation as compared to both the other ICE measures and the poverty measure. Second, larger rate ratios were observed with ICE measures at the census tract measure level as compared to the city-town level, whether those levels were analyzed separately or, very important, both analyzed together in the same model using multi-level methods. Third, the index of dissimilarity showed no associations. We obtained similar results for the non-fatal assaults, and for both the fatal and non-fatal assaults, the patterns were most extreme for the firearm-related assaults. Now, the finding of greater sensitivity to inequities at the census tract compared to city-town level is not surprising. It's what one would expect given reduction of variation caused by aggregating to higher geographic levels. But it's critical to recall that most studies on segregation in health do employ only city-town level measures of segregation, and this suggests that the effects that they report of the harm done is actually underestimated. The finding of no effect for the index of dissimilarity is likewise striking, given its widespread use in research on racial segregation in health. So together, these results suggest that the census tract ICE measures may be useful addition in public health as a monitoring to be part of our toolkit. Our newest study extends these results from Massachusetts in 2 ways. First, we examine a variety of mortality outcomes, including child mortality, that is death before age 5, premature mortality, defined as death before age 65, and several types of cause-specific mortality for cancer, cardiovascular diseases, diabetes, suicide, HIV/AIDS, accidental poisoning, which includes drug overdoses, and smoking attributable mortality. Second, we examined whether there was any effect modification by gender or by race ethnicity, mindful that residential segregation is rarely by gender, but is pronounced by race ethnicity. And this slide shows results for child mortality, selected because it illustrates the main kinds of findings that held across the diverse mortality outcomes that we considered. In the multi-level models, jointly including census tract and city-town metrics, the rate ratio comparing the worst to best-off ICE quintile for the total population ranged from a high of 2.2 for the racialized economic segregation to a low of 1.1 for the city-town level ICE for racial segregation. We obtained similar results by gender and for the non-Hispanic white population. Larger associations, however, for the ICE for racialized economic segregation occurred at the census tract level for the Black non-Hispanic population with a rate ratio of 6.9, at the city-town level for the Hispanic population with a rate ratio of 6.4. To our knowledge, these types of multi-level patterns that affect modification by race ethnicity have not previously been reported. The finding of effect modification by race ethnicity but not gender of associations between ICE and mortality rates likely again reflects how U.S. neighborhoods are segregated by income and race ethnicity but not by gender. And with racial residential segregation at the city-town level remaining a profound structural determinant of racial health inequities in health, wealth, and myriad other outcomes above and beyond conditions in one's immediate residential area. Of note, we also found similar results in our other new study that's just been accepted, which is focused on Massachusetts cancer incidence and mortality data for 3 types of cancer: breast, cervix, and lung cancer. So to improve monitoring and analysis of health inequities, we are recommending that health agencies should routinely use measures of spatial social polarization that can be employed at multiple levels with data presented for both the total population and stratified by relevant social groups. Taking such steps will help clarify how the larger social context, including growing extremes of privilege and deprivation, that is, the other kind of inheritance, are differentially affecting people's well-being and becoming embodied in health inequities. And so to wrap it up, it's long past time to emphasize the importance of societal inheritance for population health and health equity way over and above genetic inheritance, however important it is to understand aspects of the genome and people's health, and particularly the kinds of medications they take. As both backdrop and foreground to the statement is the long-standing use in the U.S. of self-serving arguments, the social order reflects the quote-unquote natural order of inborn superiority and inferiority along the lines of race and class and also gender, when in reality the social order reflects ongoing reverberations of the U.S. having been founded as both a settler colonial nation and slave republic in which the original franchisement, that is, ability to vote, was restricted to white propertied men. Here I return to the example of Charlottesville to argue that confronting this history allows for new possibilities for expanding health equity and changing patterns of societal inheritance. Notably, on the same day that Boston had its huge counter-protest against the alt-right, the New York Times published an investigative report which focused on links between racial discrimination, voter suppression, and the 1960s destruction of Vinegar Hill, then Charlottesville, quote, thriving black cultural and economic hub, end quote. The report pointed to a crucial fact well known to the black community but long disregarded by white residents. Quote, in a time when a poll tax kept many black residents from casting ballots, Charlottesville held a referendum in the early 1960s and decided by a margin of just 36 votes to raise Vinegar Hill for redevelopment. Hundreds of residents and 29 black-owned businesses were displaced, most never reopened, and generations of black families have been trapped in public housing complexes since then or have left town altogether, end quote. Crucially, the article also points to how new leaders in Charlottesville have used this type of structural analysis to inform some potential solutions. Quote, the same day it voted, February 6, 2017, to remove a statue of Robert E. Lee from a park, a move that white supremacists descended on the city to protest, the city council did something that got much less publicity. It unanimously approved a $4 million spending plan to address racial disparities. Over the next 5 years, about $2.5 million is to be used to redevelop public housing. $250,000 will go to expanding a park in a black neighborhood, and $20,000 a year will pay for GED classes for public housing residents. Activists call it reparations for destruction of Vinegar Hill and other black neighborhoods here, end quote. So in closing, and to reiterate what I said earlier, the historical record is clear. What has best enabled societies to improve population health and promote health equity has been the societal regulation and restriction of massive concentrations of private inheritance, along with the promotion of public inheritance and support for shared and inclusive knowledge. To change the odds to favor health equity, we need to be cognizant of this history, tied to a vision premised on social justice, along with deep recognition of our interconnection with and dependence on our wondrous and threatened planet. Thank you. So that was a lot, and it was meant to be. But this is a chance now for Q&A.
Thanks so much for the talk. It was wonderful, and it's very nice to hear you speak live. Let me apologize in the beginning. The concepts were so huge and important. Now I'm going to ask you something that's very comparatively minor. So your ICE metric, which is it's beautifully simple, right? It's very attractive in that way. So you mentioned some of these kind of local measures that you were looking at. I'm guessing it's like the David Wong kind of stuff. Would you feel that doing the multi-level version kind of accounts for, or is good enough for the edge effect and things like that David Wong was trying to avoid? Or do you think doing one of these kind of more local versions might be different from your findings?
So I think what's important in your question, and I won't go into all the technical parts because not everybody will hear or will even know what you're meaning by edge effects, but what's important is that the kinds of measures that I work to develop are meant not only for specific research projects that are done by investigators who have time and resources to do them, but also can be used by health departments for monitoring health. And most health departments, New York City is remarkably well-resourced in terms of the epidemiologists and biostatisticians who work there, and it's unusual for health departments. So I can imagine, because I work with them on projects, including with this ICE, that they could play around with much more complicated statistical models. But what I always like to do with my work is see, for the work that's meant to cross the etiologic research and the public health monitoring, is what can you get away with that's good enough? that tells the story. So that's the frame of this, which is geared very much to public health monitoring, as well as to spur the kinds of ideologic research. I think a useful question, like we found, for example, in the work that I did previously on the poverty measure, if we took into account spatial autocorrelation, did it really make that much of a difference? And the answer was no. So I think those are the kinds of questions that people who have the resources to investigate, to see just, are we, and always asking the question is, do what we do underestimate a bad effect we're trying to capture, or does it tell the story reasonably well? Or does it inflate it beyond belief and it's completely deceptive and misleading? My sense with the multi-level models that we've been running and the playing around with permutations of fixed and random effects is that we're telling an accurate story. And we're also telling a story that, again, this is why I so appreciate what Douglas Massey did in conceptualizing the ICE, is that it's really easy to get your head around. And people are starting to, and so I find that a measure, if it's going to really be informative, needs to be reasonably transparent. The quantities are easy to show. You can show your preferences as to who you're saying is privileged versus deprived of privilege. You can make it very clear. It's completely, when we do census data, it's completely accessible data. I mean, yes, we all have to deal with the uncertainty of the ACS data and what does it mean, and all. I mean, we can go off on a whole geospatial tangent. But I think the answer to your question is we haven't specifically tested that hypothesis. But I've seen some of the measures that are put out for local residential segregation that are much more complex spatially. And part of my initial response is good luck getting any health department to use that. There's a question back here, and then.
Okay. So I'm thinking about what you had a lot of big concepts here, and essentially.
Would you speak up a little? Hold it closer.
A little closer.
Thank you.
Okay. Sorry about that. Wonderful talk, and thank you for that. And I'm trying to think through, what do you think, given your talk, are going to be impactful regulations? Because even something like the 421A tax credits in New York, you saw things like a poor door being created for people in the affordable housing. So I wonder, what are really impactful regulations that might combat some of these drivers of health inequities?
There are many different answers, and I think that one of the important things is different local communities are figuring out things. Charlottesville, I was giving at the very end one example of what they're doing specifically because of the way that redevelopment and gentrification was carried out. And different communities are arguing different ways of doing that. So I can't give a one-size-fits-all. What I can say is that if these issues aren't discussed, the policies won't be even thought of or demanded, let alone implemented. So I think you're raising a good question, but this is saying, let's bring up the level of discussion. It doesn't mean it becomes a national question. Right now we have a national government which probably is going to exacerbate, not ameliorate problems, but there's local action that's actually people are taking. People in my state in Massachusetts right now are working on a new bill that will direct a new tax that's only to millionaires that will go specifically to education and transportation, and has a particular eye on some of the spatial aspects of transportation that's not working for people that are in neighborhoods that become transportation ghettos in effect. So that's, like, I can tell you that's one thing that's happening in my state, and there's quite the political fighting going on about it, but it's going to be on the ballot initiative from what it all looks like, and it's beginning to gain some steam. So I think this is where I would never question the imagination of people who start to get it in their minds that these are fixable and not permanent problems. And again, comes to the flexibility of inheritance. You can change it. And the laws that made inheritance be what it is now, getting rid of the tax on estates, that's a decision. It can be made not a decision. It can go to something else. So I wouldn't want to give one prescriptive example, and I also wouldn't suggest that it's easy. Obviously, this is entrenched, and that's what we know, but we also know that there has been change.
Thank you so much for that wonderful presentation. The idea of embodying inequality is something that I think people who are thinking about the impact of immigration policies on health it's been very meaningful to me as I think about how I might approach a dissertation topic. But that is very challenging because for lots of good reasons, it's very hard to get very concrete information on immigration status as a determinant or as a variable. And this may be one of those questions that doesn't have one good single answer, but I'm wondering if you have any thoughts on, or if you're aware of any work that's really trying to capture the health impact of immigration status or immigration policy.
So there's actually a lot, and all I'll say, I can't say anything because it's still in the works and about to be submitted probably next Tuesday if all goes well. I'm working with the New York City Health Department on a project exactly along these lines to try to look at what some of the impacts of what we're calling severe socio-political stressors are on outcomes, including in relation to all the anti-immigrant as well as anti-Muslim as well as anti-Mexican rhetoric that's been flying around, in addition to other entrenched forms of racism. But looking at that literature, there's a study that was just published a few months ago in the International Journal of Epidemiology by Wilhelm Johannsen et al., for example, was looking at one of the hugest raids that the immigration authorities did on a town and the workers, and looking at the impact on both the Hispanic, U.S.-born and non-U.S.-born on birth outcomes in comparison to the white population of the town, and found a huge effect, a 24% increase in risk of low birth weight babies, and doing before, after, and proper econometric modeling and blah, blah, blah. And there are other studies that have looked at that as well. So that's in terms of the actual deportation raids, but the fear of those raids. And there's other work that's the Kaiser Family Foundation just put out a report that's more ethnographic, that's looking at the levels of fear that families have and the impact that it's having on their children. There's work that's out now already on documents. It's becoming increasing in frequency since, I'd say, probably 2011 in the literature on people not going to see healthcare providers because of fears. So there is actually a non-trivial body of work. I mean, it's not huge, but I mean, welcome to social epidemiology. And so compared to the mainstream, but it's there. And it's looking at specifically the immigration status in terms of legal and undocumented. And also, there are other things that go on that really matter about immigration status, the number of years in country. And there's work I've done, others have done as well, how people understand discrimination, particularly racial discrimination. It takes some time, if you're not from the U.S., to have any clue as to what's going on in this country. And what do you experience as rudeness versus understanding what is racial discrimination? It takes time. What happens from one generation to the next generation? What happens when kids go to school? There's a lot going on. So that's a whole other piece around immigration as well, which is what people understand when they come to this country about what this country is about, and then what do their kids understand when their kids get exposed. And so there's lots of different ways to weave that in, and there are health studies that are looking at all of that. And so I think it's, again, about contextualizing, and it's not just about acculturation. It's the context. I mean, imagine moving to a country that had, like, greater racial equity. That would be nice. You'd see that happen, too. You don't only embody bad things. You embody good things. That's called public health.
Hi. I also applaud the presentation, and I have another question, though. We know that there's a very big gradient in health and mortality between hourly workers and salaried workers. And it probably has to do with the nature of the work that they do and other factors that are brought into it. And we also, when we look at socioeconomic status in terms of income, you have these anomalies of, like in West Virginia, the coal miners get paid a lot more than the teachers do. So it's just a thought, how do we take that into account? My impression is that if you have an undefined variable, it degrades the statistical significance of the things that you actually do measure, and that you would have a sharper distinction than comes out from these works.
So I think what comes out in your question usefully is that work is about a lot of things. And also the fact of not having work, being unemployed or being completely out of the workforce. And what it's about is the standard of living that you have, it's about the interactions that you have, and it's also about the physical exposures that you have. And that's both at the workplace and also if you're not at the workplace. So yes, there has been a history of having a wage reward for people doing quote-unquote hazardous work, usually constructed as men, as a part of what's typical masculinity, that it's just normal that you just do really hazardous things and maybe get paid better. And those are questions that people in our space can ask about and say, wait a second, that doesn't make sense. Nobody's supposed to be exposed. And one response that had happened, as you well know, in the lead industry was first the attempt to exclude women from being in lead exposed jobs, as opposed to thinking, maybe lead might do something to men, including to men's sperm, which also has implications for the next generation. So there's a way of thinking about who gets to be exposed to bad conditions and allegedly get more pay and say, well, wait a minute, what's the point of a job? Is it to get an income or is it to live a better life? Well, if to live a better life and your health is being compromised, but you're getting a slightly higher income, what's that about? Who's making those equations? Who's doing that calculus? So when you're thinking about something where you have to take into account occupation is part of it, but it's getting you a standard of living, which has to do with where you're going to live, all the housing exposures, the schools, all the tax base, all those things. But it's also going to be around a set of material exposures at work, and it's also going to be about social exposures. So I've done research that links the likelihood of experiencing sexual harassment and racial discrimination and bullying at work, in addition to what it means for their health outcomes not at work. Right? I mean, you want to look about what people are doing, what's happening in their home. And that study was trying to link people's experience also of violence in their homes to also what did they experience at work. These things come together, and there's reasons to understand their links. So I think your question is asking to think more broadly and to think that, no, obviously income is not the only determinant of what people's health is, but it's going to tell you something about the tax base of the community, and then what will be the resources that come from that. There's a question here, too. Sorry.
Yes, thank you for an excellent presentation. And just to build on to the last comment, it was interesting to see the map that you showed of the Jim Crow laws also overlaps with what traditionally had been mostly right-to-work states, and everything that has to say about access to health care, jobs with health care, jobs with pension, and everything you just said now. And I think it's a great way to look at that, and I don't think we mind that enough. So thank you.
Right, and I think the thing again is to understand that many other people besides people concerned about health are concerned about social justice. So where does health help bring some questions to the table with clarity? And some are, what's the cost? What's the biological toll of these decisions for us now living and for future generations? And what's it done to us living now in terms of what happened to prior generations and the legacies that we carry? So I think that those are useful questions. I would never want to suggest that health trumps all, as it were. It doesn't. Rather, the idea then is that equity in all policies should be good for health equity, which doesn't mean that that's not the same statement as health in all policies. And that's something that your Commissioner of Public Health in the city, Mary Bassett, my colleague, has made repeatedly, and I think it's a really important point. But we get to do the homework to see, and do the research to show, well, is that actually true? And that's an important job. It means there's extra bennies. If you have equity at work, it should translate into better health equity. If you have equity in education, it should translate to better health outcomes and better health equity. So that's an extra challenge for us. It's our job to figure out how to do the health impact assessments. But it's not saying health is the only metric. But it is saying, if you want to ask what's an economy for, is people's well-being part of that answer?
That was a fantastic presentation, Dr. Krieger. What I really liked about it also was the metric of the ice. It's a real icebreaker, and I'd say that it's a great way to look at complex interrelationships in a causal way. So I just was curious, what level would you be able to use ice at the highest level, say First Nation, and then all the way down to even say zip code, for instance? Because I'm looking into exploring.
Yeah, no, you can use it. I mean, the value of it is you can use it at multiple levels. So you'll see that there are plenty of studies, and very fortunate I have my colleague Janet Gornick here, who does work with income inequality measures that are at the national level. She's at the CUNY Center for Social Sciences, and if you're interested in any of that, you should definitely talk to her. But you can do, there's all these studies that use the Gini index at the national level. And the thing is that it runs out of steam when you get to little levels, precisely because of the geographic separation of who lives where.
Yes.
But the ICE doesn't run out of steam, and the ICE, to my knowledge, has not been used at the national level, and it could be. Why not? I mean, as Massey designed it, it was clearly meant to be used at multiple levels, and it also, we're the first to use it at multiple levels in the same model, to really take a multi-level complex framework to analyzing the data properly. And that, any other people could actually do that, and so I would encourage that. I would encourage, we have started to, with the SEER registries, because of the 18 and 13 SEER registries that we've used, they're in different states, so we can bring in some state stuff, and we've brought in county stuff. But the thing is, what are you really getting at when you get to those higher levels? What is that differential telling you? And you can see it more in terms of some of the interactions and the base that would happen at a very small level. You can do the ICE down to the block level for race ethnicity, given U.S. data, because people should know the reason that the block data exists is about voting. It's about the Voting Rights Act. You have to know the race, ethnicity, and age of people. That's why you can get those data on race, ethnicity, and age, unless, of course, Congress goes and decides to not only, who knows what they want to do to gerrymander the census, but that's why you get that. The next level up you get is the census block group. That's where you can get some initial statistics that are also on economic and housing and otherwise. That's all complicated because of the ACS sampling frames, which is a whole, and the uncertainty behind them, which is messy. So it's probably wiser to stick with the census tract than the block group, and you also have to aggregate a bunch of years, because you can never use single year estimates from the ACS, that is just the census tract level, that is completely foolhardy. It's just wrong. And so, and the census almost tells you that. And then you can take it up, because there will be city-town levels, there will be county levels. If you're in Louisiana, you'll have parishes. You have to deal with what the local levels of geography are. And they're not just abstract levels, they're usually levels of governance, and therefore levels of accountability and also of budgets and of resource allocation. So you need to know something about what the levels are. In Massachusetts, city, towns are relevant. Counties are basically, not really a particularly germane unit of government, so they're not particularly informative. So you have to know something about where you're looking at these different levels. But you absolutely can keep on taking it up. If you're in a different country structure entirely, you'll have provinces. You just have to adapt it. But the idea is that it can work at lots of different levels, and that's one of its positive features.
Yes, thank you. I just wanted to be sure that this wasn't only like a really useful measurement just in the sense of some small tiers, but that it has much more applicability. And you know what? Thank you. I'm thinking of definitely using this and incorporating some form in my capstone when I do it. So thank you very much for furthering education as usual, Dr. Krieger.
Glad to be of help.
Hi, Dr. Krieger. Thank you so much for the great presentation. So my question is around the data that you've been collecting, the research that you've been doing. Is there any plan to really kind of focus a little, more specifically around intersectionality? So not only black versus white, but what about black women, black and Latino women, the LGBTQ community, how all those intersections of identity kind of factor into health equity?
So thank you for that question. So there's so much you can do with census data for the ICE measures. And thinking about the geographic segregation of people, the biggest drivers are permutations of race, ethnicity, and income in terms of residential segregation. But absolutely, you're right that, one, just like we embody everything, and we are not one day a straight person versus queer. We're not one day someone who is white versus African American or Asian American or many different things. We're all those things at once, our class and everything. So in one sense, intersectionality is happening in us every day. And a lot of the work on intersectionality tends to stratify people into the different categories and then compares risk, but it's not necessarily as much focus on what the differential exposures are that are driving the differential risks in those strata. So I have a grant that's under consideration right now that's working specifically to try to figure out how one measures, knowing that individuals can experience lots of stuff because of who we are in the world, how you simultaneously deal with discrimination based on whether you're gender minority or sexual minority status, age, race, ethnicity, weight, things like that. How do we, one, measure all those things? Two, how do we actually statistically model them in a way that's meaningful, that understands what the multiple types of adverse exposures are, bringing in a lot of other background stuff. So I think these are really important questions. The ICE, we have played around with the ICE in terms of looking at U.S.-born, foreign-born. We've played around looking at Latino, Black. We've turned Latino, or the way the census calls it, Hispanic versus white non-Hispanic. We've played around with those different ones. The thing about Black-white segregation in the U.S., it is the most powerful and enduring form of residential segregation. That's by race ethnicity. Way stronger than for any other group and with a much deeper history. So it carries a real imprint with it. And so again, when you're thinking about monitoring measures that you want health departments and cancer registries and others to use, you're thinking about what are some key things that wake people up to what the phenomenon is. And it will not have all the nuance of an etiologic study that is much more carefully designed with different populations. In the U.S. Census, you will not get the data you want in terms of, I mean, there's really lousy data on same-sex households. It's like really lousy. I wouldn't trust it ever. So I wouldn't ever recommend that for using for an ICE measure, for example, because I mean, you want to have good data, not just data. So you're going to be very hard-pressed to figure out that kind of question using census data with the ICE. But you certainly can ask those questions and get at some of these kinds of issues, you know, through when you actually have surveys. And I think the thing is to be recognizing one of the other important values around some of what comes through with the intersectionality frames is that, you know, there's pluses and minuses of things going on. Gender inequality, for example, is, as we've just talked about, some of the ways of what gets called toxic masculinity can increase men's risk for certain kinds of outcomes, even as it decreases risk for women, but women are getting increasing outcomes, bad outcomes in other ways. It's not one happy, simple picture that everything all adds up equally in the same direction. But there are some things that are generally pernicious, which is inequality. So that you have to figure out the specific forms of it. Breast cancer that I work on is a complicated disease for that reason. Incidence generally increases with affluence, but survival and mortality is worse with deprivation. All of that's true in the same sentence. So that's different than something like tuberculosis, where incidence, survival, and mortality all go in the same direction with a deprivation measure. So those are the things where biology says, we're going to do biology. We don't care if you people want us to line up all in a nice way and every disease outcome to just behave the same way in relation to these different measures. No, that becomes what our job is to actually interrogate. But you're raising critical questions. I don't think the ICE is going to do what you want it to do, but I think there are ways our research can bring that in and can ask about the context in which different types of groups live in different kinds of contexts. And defining that context is as critical as is defining how people self-identify themselves, and also understanding that the self-identities are not just simply chosen because, oh, it's nice to identify as X, Y, and Z, but often because of the histories of legislation that force those categories into being. There's a question back there. And then I see there's a question over here also.
Good evening. Hi. Thank you so much for your presentation. My question has to do with incarceration, particularly populations that have either been released or are currently incarcerated. With incarceration, it kind of can lock in segregation. And so I wanted to know if there's any data you've come across with particularly mothers and pregnancy or birth outcomes for women who have a background or.
So you're asking a great question. There's not a lot of data right now. There's beginning to be. It's actually, what you're talking about is exactly what one of my new doctoral students is focusing on for her dissertation. And so she's just defended her proposal, so she's been busily reviewing the literature, and I would be happy to put you in touch with her. If you email me, I can do any introduction. And so she's looking exactly at that and trying to figure out ways to begin to ask these kinds of questions. And so the issue is not only also what the impact is of the mother's incarceration, but also any family members and what that does to communities. And we just had an event at school also that was on incarceration, genders, and health. And we were actually working with some of the groups that are doing advocacy from the inside in amongst who are people that were previously incarcerated are part of the panel, and also working with some of the community health centers that are helping people transition as they get out to be hooked up to community health centers, and talking about the kinds of health issues that are going on both in prisons, but also when people get out of prison. And that's absolutely a critical part of what needs to get looked at, and needs to get looked at across the life cycle.
Thank you so much.
There's a question here.
Thank you. Thank you so much for this talk. Your work continues to push the conceptual and methodological boundaries. You've also done a great deal in terms of social justice in public health, and I wonder if you could give us a little bit of your thoughts about public health, where the field is now, and what we can do to promote, to help more people in public health and the field promote social justice, sort of beyond the specifics of this research.
So that's a great question. It's also a big one, and I see things happening like with the American Public Health Association, which is one bit, and it's actually a pretty big group. And what's been gratifying is seeing over the past, the spirit of 1848, which I co-founded back in the mid-90s also, when we were initially doing some of the work, putting out questions around discrimination, economic inequity, gender inequality, LGBTQ, oppression, and health, it was like there's hardly anybody else doing that. The Black Caucus of Public Health Workers had always been doing that. There was a Socialist Caucus, but it was like the caucuses were doing little things, and the association as a whole has been picking up the theme more and more, which might be in some cases seemingly more lip service, but it's important that it's been rising on the agenda. And the idea of quote-unquote social determinants of health, or as more critical colleagues in Latin America would talk about, as societal determination of health, because somebody's doing it. It's not just determinants drop out of the sky. They're a result of decisions that people make. Is becoming, I think, more understood. What that translates to, there's the health impact partners who have been doing a lot of work and training people in local health departments about how to become even more active and engaged and become advocates for working. Sometimes when there are very few people in a given health department who have a social justice perspective, they can be very isolated. What can be done to start to change the practice of health departments? So there's a lot more attention to that. There's a National Collaborative for Health Equity, which is doing a lot more work as well. That's looking at not only place matters, but how health departments engage with that. The National Association of City and County Health Officials, NACHO, has a whole bit of programming that's specifically focused on understanding roots of inequality. They have an online course to help people in health departments better appreciate that. So I think there's more resources out there. But I think a key thing is very much with public health, and it's certainly what we'll be exploring in our 1848 sessions with the upcoming APHA meeting, is the need to articulate who are our adversaries as well as who are our allies. Because all too often it gets framed as, well, yes, it's bad for, these things are bad, but not why is it continuing and who's benefiting from it, and what does that mean about the alliances that need to come back together. And that comes back to your point again about intersectionality, not to have it be divisive, but actually to figure out what does that mean about who's allies. And what does it mean to understand what the connections are between issues. And I find that the biggest point is right now people also beginning to figure out that there's actually a real connection between climate change and health inequities, and also on average population health. And what's happened is for too long these worlds, which you think, it's like we only have one planet, but hey, the worlds have been completely separated as if we lived on two, as if there were a social world, and then there was the world that was sort of environmental and ecological. It's like, actually, no, it's one planet, and that's us. And we better stick these things together because our bodies are, and the bodies of other organisms are, and we lose pollinators, we got a problem. Songbirds are greatly on decline, but people also respond as people. They tend to go, oh, that's nice, go hug a polar bear. And that has limitations. So understanding something about people means also understanding what's happening around health and health inequities. And what matters around health inequities in terms of the gross injustice of the peoples and populations that have produced the least fossil fuel excess risk to the planet are the ones who are going to be hit hardest and are being hit hardest. So that's a big social justice question, to put it politely, that's enormous one. And what happens, it's up to us to decide. And by the us, I mean in that the people in this room, the people in our generation, because this is this one you don't get to watch the pendulum swing. It sort of is like pendulum. So it matters. It's not just a political fight. And this is where I think public health bringing out the well-being of people, and that well-being requires a well-being with the planet, is actually really important, and it's evidence-based. And we have to understand that and make it clear that it's not just science, and you can't just have a blue-red team. For Scott Pruitt won a debate, does climate change matter, A, and B, is it real, and C, is it driven by humans or not? But I guess you could have that conversation in this very private phone booth.
If there is no more questions, I would like to thank Professor Krieger on behalf of the Department of on behalf of the Department of Epidemiology and Biostatistics and the School of Public Health.